Hello everyone, good evening. So, NEET PG 2023 is round the corner and all of you are preparing for it. I know a lot of rumors are going on in the industry, in the market over here. A lot of people in the school, colleges, are telling you exam might get postponed. We are going to Health Ministry, now they have gone to Supreme Court. Just remember one thing, exam is not getting postponed. Okay, you have to have your focus maintained, right? Okay, and to help you maintain that focus, we are doing this series. Today I am here, a lot of other faculties have been here to discuss the most expected questions of NEET PG 2023. I'm Dr. Sarvejeet. I'm your very own ENT faculty and I'll be taking up the subject of ENT today. Now, before we start this topic, okay, now you see most expected questions. So when I say most expected questions of ENT, are these the questions which are going to actually come in the exam? Maybe, may not be. So why I have put this question? Because if these questions do not come in the exact way, in some or the other form, they will come. These are the important topics. More importantly, I have kept these questions over here to tell you the various tips and tricks that you are likely to make mistakes. You know, a lot of times, and this has been happening ever since I cleared my exam, and I have been talking to my juniors that, sir, I am going to get 70% marks in the exam this time. Even I have seen all the recall, I have seen all the videos, I know I have calculated my marks, but when the actual result comes, it is way lesser than that, right? Okay, so good evening. I can see a lot of you have joined, right? Deepak, Apurva, Mithu, Manohar, Sinuvasan, right? Miss Kaur, good evening, right? So yes, so I was saying that a lot of you, oh, even Dr. Aman Setia is there. So a lot of you will say that I'm going to get into the top 500, top 1000. But when the actual result comes, you are expecting 550, it's actually 350. Why? Why? Despite preparing, despite, doing the paper to your best, despite checking the recalls, your marks are not as per expected. No, that is what we are going to discuss today over here. We are going to see where you make those blunders, where you make those mistakes. Okay, so now there are two types of mistakes, there are two types of questions. One type of question you do not know. You have not read that topic, you have not read that particular question, you don't know the answer, that's okay. Blunders are the questions where you have read the topic, you have revised it, you are fully prepared, you know the question, and yet you mark it wrong. Those are known as blunders because you are confidently marking them wrong. Okay, right? So that is what we are going to make sure that you don't do it today. All right. So let us discuss, let us start with this topic, and one by one we'll come and we'll see what all tips and tricks are there in each of these questions. All right. So the first question of the day over here that I've kept is a 60-year-old male presented with left ear discharge for the past 7 years with dull earache. Okay, so 7 years history with dull earache. On examination, the tympanic membrane is intact on both the sides with discharge coming from posterior canal wall on the left side as shown below. Okay, so we can see this photograph. We can see this photograph. So this photograph is given to us. Let's look at the question once again. 60-year-old male presented with left ear discharge for the past 7 years. Okay, so whenever you get a question, you start bifurcating it, you start dividing it into small parts. The questions are going to come as clinical to you, right? So whenever clinical questions are going to be there, if you read 3-4 lines, you'll forget what was given in the first line. You may end up missing something very important, something very crucial. So we are going to divide the question into different parts. We are going to make it a mathematical equation. Okay, right? So 60 years is important, male patient with left ear discharge for the past 7 years. Long history, chronic disease. Okay, so long history means chronic disease. On examination, intact tympanic membrane on both sides with discharge coming from posterior canal wall on the left side as shown below. So we can see this photograph. What do you see? You see the tympanic membrane is intact, and you can see a red inflamed, EAC wall, right? Okay, anything else can you see? Can you see any growth over here? No, you cannot see any growth over here, right? All you can see is a red inflamed EAC wall, right? Okay, now the question says hearing is normal. We can see the tympanic membrane is normal. What is the most likely diagnosis? Come on, right? Okay, so I'm waiting for your answer. Yes? Okay, why so serious? I am not serious at all, but clearing the exam is a serious job, right? Okay, so it's a very, very serious job. So let's focus on this job. Let's do our best. So come on guys, tell me the answer. Okay, Archana, all right. So yes, I have given you the first hint, 7 years, it's chronic. Why can't it be, low potency carcinoma? Why are you not thinking of in terms of malignancy? 60-year-old patient, you see, 60-year-old patient, right? Why are you not thinking in terms of malignancy? Okay, can it be keratosis obturans? Come on, can it be keratosis obturans? We know it is not CSOM. Tympanic membrane is intact, it is normal. Okay, look at the tympanic membrane, it's absolutely normal. So it is not CSOM, that is ruled out. Okay, right? Okay, what else can be there? Keratosis obturans, that's a collection of wax, collection of dead epithelium, all of that blocks the EAC. You are not able to see the tympanic membrane. Is that the scenario over here? No, not the scenario. So it is not keratosis obturans. Okay, right? Chronic discharge, it can be chronic otitis externa. We can see there is inflammation on the EAC wall. Do you see any kind of growth over here? No, there is no growth. Okay, there is no destruction, there is no growth. So therefore, this cannot be even carcinoma of the EAC. Normally, the carcinoma of the EAC will not have a long history of 7 years. Okay, but I said very, very low potency. Even then, you will see some granulations, you will see some growth. Okay, that is not the scenario over here. So the answer over here is chronic otitis externa. Right? Okay, right. So yes, Ferin, Akshat, good. Hearing is normal. Very good. Okay, let's go to the next question. So you see, whenever you are attempting one question, so the tip over here, what tip did we get? What tips did we get by solving this question? Number one tip that we get was to break the question. Okay, to break the question, make it a mathematical equation. Okay, make it a mathematical equation. Now when you break the question, you don't have to pick up everything. You have to pick up only a few significant points. Like over here, I picked up 60 year, I picked up 7 years, left ear discharge. I forgot the male over here because I thought it's not relevant over here. I have underlined it. If needed, I will use it. Otherwise, I will not use it. Right? Okay. So not all points have to be used sometimes. Only a few will give you the right hint. So you have to pick up those important points over here and use them to make a mathematical equation. Right? What else? What else? Now, if you want to be absolutely sure about what you are going to mark, rule out other options. So by 7 years, we had deducted chronic. So there was only one condition that had chronic word in it, chronic otitis externa, right? But you have to rule out all the other options, right? That will make sure whatever answer you are marking, you are 100% sure about it and you get the answer, right? Okay. Now, what other tip did we get from this image? So image is very important. Now today I have kept all the questions which have images, right? Because I wanted to show you images, and I wanted you to understand how to deduct information from the images. At the same time, now almost 80 to 90% questions that are coming in the ENT are image-based questions. So I have kept all the images over here, right? So these are the 3 tips that we got from this question. We're going to use these tips in the next questions as well, and we are going to see what all we can get from those questions. Okay, now the next question. A 30-year-old patient presents with pain and discharge in the ear. You see, similar history. There it was 60 years, here it is 30 years, right? Not much difference, right? Pain and discharge. On examination, ear shows the following, right? Okay, he should be managed by. So now what do you see over here? Now, pain is there, discharge is there, so they were there in the previous question as well. They are not contributing much to the question over here. This is basically a spot diagnosis from the image, right? Okay, so yes, come on, please, I'm waiting for your answer. Okay, first before you go to the answer, tell me what is the diagnosis? What is the diagnosis? Okay, so Srinivasan is saying A, Daphne is saying A, Akshat is saying D. Oh, Farron is saying B, Mithu is saying A. Wow, so different answers by each of the students. Okay, so that is why I said first make the diagnosis. Come on guys, tell me what is the spot diagnosis over here by all of you. Okay, if you know the answer, then you can tell if you know the answer to the diagnosis, you can tell the answer to this question as well. Okay, so Farron is saying mycotic external otitis externa. That's a complicated term. We have a simple term for it. Ritu, come on. Yes, what's the answer to this? What's the diagnosis? Automycosis, yes. Why make it so difficult? It is automycosis, right? Okay, it's a clear-cut spot diagnosis, yes. So, you know, automycosis, the most common presenting symptom is severe itching in the ear, okay? So, most important presenting complaint of the patient is severe itching in the ear. I agree, right? This is the most common presenting complaint. But the patient can also have pain. Patient can sometimes also have ear discharge. Now, when I was making this question, I have very cleverly omitted severe itching from the question, right? To make the question interesting, to make the question little bit more complex, I have eliminated that. Because sometimes in the clinical scenario, patient is not much bothered by itching. Okay, he's used to of itching. He's bothered by the pain and the discharge which has just arisen. All right. So a lot of time in the clinical scenario, we get such patients who have only pain and discharge. And anyways, the history is not contributing much to the question over here. The answer is provided just by the image. When you look at this image, you can see all these fungal spores. Okay, they're rising at the EAC wall, right? So it is a clear-cut case of automycosis. Now, what treatment do you do for automycosis? Yes? Okay, Daphne, English चाहिए आपको थोड़ा सा, तो ठीक है बेटा. We'll try to use both English as well as English because some of my students are also from South. तो ठीक है. राइट तो ऑटोमाइकोसिस डायग्नोस हो गया आपसे. क्यों डायग्नोस हुआ? क्योंकि स्पॉट डायग्नोसिस था, इमेज बेस्ड. राइट, ट्रीटमेंट क्या होगा ऑटोमाइकोसिस का? व्हाट इज द ट्रीटमेंट? सो नंबर 1 ट्रीटमेंट फॉर ऑटोमाइकोसिस इज ऑरल टॉयलेट. You have to clean the EAC. This is the number 1 treatment. Okay, followed by topical antifungal ear drops. Now this, what I am telling you, is very important. Yes, so topical antifungal ear drops. Akshat, yes, correct. Out of this, clotrimazole is the answer over here. Okay, it is clotrimazole, not clotrimoxazole. Okay, I can make the question little bit more interesting. Instead of clotrimazole, if I can put over here clotrimoxazole eardrops, now that will be a wrong answer. So sometimes examiner are shrewd, they can make such kind of choices as well. Okay, so be careful what you are reading. Okay, check it. Examiners these days are very shrewd, they can just change a little bit over here and change the answer. So as I was showing you, okay, so if this is given, it's given to trap you. Now, if so steroid drops are not at all used, ciprofloxacin again not much use, there is no wax over here, so wax softening ear drops also. You see, again I know my answer, but I am ruling out other options. Now, if over here, let's say instead of this option, I could have given the option D as oral toilet, then that was a better option. Remember, this was a better choice. Okay, right? So you see, oral toilet was a better answer compared to topical antifungal ear drop. That could have been used. All right, so now we know the answer. But why are we here? We are here to understand how not to repeat the same mistakes in the exam. What are the takeaway tips, the tricks from this question? Okay, so you see over here, we again broke down the question, we tried, but that didn't work. It was a spot diagnosis. Okay, so sometimes image-based questions are spot diagnosis. Okay, the clinical history will not help much. Okay, they are what? Spot diagnosis. So clinical history does not help much in that scenario. So if clinical history is not helping you much in that scenario, so that means it is better to look at the image first, right? Okay, so image has to be seen first, right? Okay, look at the image first and then you can later on go to the other things, right? So sometimes looking at the image directly saves your time. So whenever you are solving an IBQ, I always say look at the image first. If the image makes sense to you, your time is saved in reading the clinical history. You can just rush through it. If you know the image, you know the answer as well most of the times. But again, always read the complete history because the examiner can twist. Now, what else did we find over here? We find it's very easy. So what is the next question tip? The next question tip is, it is very easy for examiner to modify the question. Okay, it is very easy, right? As you said, instead of clotrimazole, I can put clotrimoxazole. It's a trap. You will mark it, it will go wrong. And I can change answer over here to oral toilet as well. That's a better answer. So you see, it's very easy for examiner to change. So you have read such a question in your PYQs, in your some MCQ book. Very good, absolutely good. You are prepared with that. But at the same time, don't jump to conclusions. This is what happens. You are thinking of 550, 600 marks, you come down to 350, 400 marks. This is the place where you lose the questions, where you are total confident of the answer, but you make the mistake. Right? Okay, let's go to the next question. A very important topic from ENT. A lot of questions come from here. Identify the given peotone audiometry audiogram. PTA audiogram. Come on. Identify the given PTA audiogram. Yes, Akshat, even if you are an FMG student, you can continue with the video because what I am trying to teach you will help you as well as the NEET PG candidates. You will understand what all tips I am giving you. They are valid for both the exams. Okay, and these questions, they are clinical questions, they can come in any exam. So no harm, you can continue with my video over here. Okay, so Ritu says autosclerosis. Is it? Sure? I don't think so. Ritu? No, I don't think so. So, yes, come on. What does this audiometry, this graph shows you over here? Okay, so audiometry is a scare for every student. They think that it is something very difficult. I've tried to make it as easy as possible in my lectures, right? So simply just remember a few things about the Peotone audiometry. So whenever we talk about the Peotone audiometry, we know that the Peotone audiometry, you can do it for left and right side in the same graph. Okay, so when you are doing it for the left side, you are marking with blue color. When doing with the right side, you are marking with red color. So R for R, right? R for R. Then what else? What else? Okay, R for ring. So air conduction is marked with ring. Okay, and the left is marked with, over here the left, the air conduction is marked with cross. All right, so that tells us something. Okay, so we have over here the rings, that is the right side air conduction, and this is the bone conduction that we can see over here, and we can see that they are both near zero line. They are both near zero. So since they are both near zero, that means right side is normal. Okay, right over here is normal. Now what about the left side? You can see on the left side, both of them have come down. The bone conduction as well as the air conduction, both of them have reduced. Right? Okay, the air bone gap is not present. There is not a significant air bone gap that you can see over here. So therefore, this is a case of sensory neural hearing loss. Of which side? Of course, of left side. Right side is normal, that we have established. Right? Okay. Dr. Metroid, thank you, sir. Thank you. It's because of you students that we are here. I'm also happy to have you in the chat over here. Okay. I'm happy that you are watching my video. Right? So, SNHL of left ear. Right? Okay. So, now we have solved this question. Good. Fantastic. But again, tip. What tip? What are we going to benefit out of it? Okay, right? Yes, Akshat, yes, I give a lot of examples to make you understand audiometry. I have told you about parliament, left wing, right wing. Okay, so if you have watched my lectures, you know that is how I teach audiometry. It's a very, very important topic in the exam. A lot of questions are being asked from this topic. Right? So Peotone audiometry, each of you must know. Okay, this question comes in the exam. Now, what tip do you find over here? You know, you can get some complex images. Not all images are simple. You can get some complex images such as audiograms, such as tympanograms. Even you can even get Bera findings. Okay. Now, many a times the students, they get scared by looking at these graphs, these charts. Even in PSM, you have these statistical charts. Okay. Now, the tip over here to solve these kind of questions is that you have to analyze the images. Okay. You have to analyze the images. This analysis may sometime take time. Okay. Now, if you waste your time and you are not able to reach to the conclusion, you will be in trouble. So what will you do? What will you do? You will do your paper in how many rounds? In 2 rounds. Okay, that is the minimum. 2 rounds is the minimum. I normally suggest 3 to 4 rounds for paper. अब बच्चे लोग आप बोलोगे कि सर एक बार तो पेपर होता नहीं है, आप बोल रहे हो 4 बार करो, तो 4 बार होगा कैसे? हाँ, ये भी प्रॉब्लम है बेटा. अच्छा, मेरे से पेपर, when I used to give the paper, I used to comfortably do 4 times. And I was not a superhuman. I was an average student. Okay, just like most of you guys. I used to have very, very brilliant students with me who were my colleagues. And I have always considered myself in the average student in the lower 40%. Right? Okay, so how will we do these 4 rounds? So you see, the round one, whenever we going for round one is going to be questions which are short. Even if they are clinical, they are short, they are easy, and they are from the topics that you have done. Okay, so you can brush through them with absolutely right answers. Maybe they are PYQs which you have revised. Okay, or if they are not PYQs, they are PYTs, previous year topic questions. Okay, so I call them as PYTQs. Right, so these are those questions, and you just go through them without wasting time. Then you come to round 2. Okay, round two is those questions which are long questions. Okay, round 2 is long questions. These are the questions that you know. These are the questions that you have done. You have revised. Those topics are nicely known to you. But they will take a little bit more time, such as pure audiometry question. You are not very confident about the graph, you have to analyze it, you take some time, right? Okay, so you have to have some time for that, right? So long question. All right, then comes round 3. Now round 3 is questions that you do not know, that you are not sure of, that you are able to rule out only 1 or 2 choices, and you need a little bit more time to think about it, right? So that's your round 3, and then we have the classical round 4, when only 5-7 minutes are left at the end. Okay, and then you mark all of them simply as B or C. अच्छा, तो B और C मार्क करना चाहिए कि छोड़ देना चाहिए? चलो, इस पे हम बाद में बात करते हैं. Okay, in some other question we'll discuss that. Of course, we are talking about the NEET PG. We are not talking about the FMG. FMG, they have to attempt all the questions. This is a NEET PG, this thing. So FMG में there is no doubt, because all the answers, they don't have any negative marking. But in NEET PG there is a negative marking. So we'll talk about it later. Right? So round 3 तक समझ में आ गया. Round 1 जो क्वेश्चन आता है, याद है, वही है, कोई लैंग्वेज में चेंज नहीं है, सारे ऑप्शन वही हैं, पढ़ के आए हो, रट के आए हो, मार्क करना है, आगे जाना है. राउंड 2 कॉन्सेप्ट आता है, क्वेश्चन नया है, पूरा पढ़ना है, समझना है, एनालाइज करना है और फिर मार्क करना है. राउंड 3 थोड़ा थोड़ा आता है, थोड़ा थोड़ा नहीं आता, कुछ सोचना है, कुछ समझना है और कुछ तुक्का लगाना है. राइट, दैट इज राउंड 3. चलो, सो प्योर ऑडियोमेट्री, इफ यू हैव टू एनालाइज इट, यू गो टू राउंड 2. कम बैक टू दिस क्वेश्चन अगेन. Right, beta? Okay. Right. Let's come to the next question. Again, audiometry question. ठीक है? तो image based देखा question? क्या दिखा आपको? When you look at this image, come on, what do you see? Fair in? Yes. I don't say to revise 7 times. I say to revise 10 times. 10 times. It's possible. It is possible. Okay. One revision, you don't have the time right now. Even if you are able to do one revision, that's also okay. आदित्य 8 बार हो गया तुम्हारा. Very good. Okay. So dip at 2000 hertz. Hertz notch. Very good. So everyone is jumping to autosclerosis. Yes, Archana, Hertz notch, autosclerosis. Very good. Absolutely good. Okay. Very important topic. Always asked in the exam, audiometry and then autosclerosis. combination comes in the exam lot of times, right? So 35-year-old female patient, देखो हिस्ट्री देखो, पहले आपने आइडेंटिफाई कर लिया, अब मैं बताऊंगा आप कहाँ कहाँ गलती कर सकते हैं इस क्वेश्चन में। सबसे पहले हिस्ट्री देखेंगे, इमेज देख ली, इमेज में आप सब ने कराट्स नॉच भी देख ली, आपने जो है आइडेंटिफाई भी कर लिया, इट्स अ केस ऑफ ऑटोस्क्लेरोसिस। बट लेट्स फर्स्ट लुक एट द हिस्ट्री। 35-year-old female, autosclerosis is more common in female, presented with bilateral hearing loss. Okay, very important, bilateral hearing loss with improvement in hearing in noisy environment. Done. Paracusis willisii. That has confirmed our answer. On examination, Rinne's test is negative, Weber's is centralized. Okay, that means it is bilateral autosclerosis. Now only one side graph is given to you. Which side? Left side. Blue color, left side. Okay, now everyone who's telling me, first of all, you have to identify that there is a AB gap. Very good. Akshat, very good. You said conductive hearing loss. First thing you have to see, there is a conductive hearing loss. Now, Carhart's notch is always secondary. सबसे पहले Carhart's notch पे jump नहीं करना है. You don't have to look at the Carhart's notch as the first thing. Always first identify it's a conductive hearing loss by identifying the AB gap, right? Then you go for Carhart's notch, right? Carhart's notch at 2000 hertz of bone conduction beta. So all of you have to see that this Carhart's notch you are seeing in bone conduction, right? Okay, so if it is not in bone conduction, it is in air conduction, that is insignificant. Notches have to be seen only in bone conduction, right? AIMS people give this question. They gave a notch in air conduction at 2000 hertz and a notch, they gave a notch in air conduction at 4000 hertz and a notch in bone conduction at 2000 hertz. So everyone saw that air conduction notch, they marked the answer as noise-induced hearing loss. It was autosclerosis. So that question has come. They have played that trick, right? Okay. So this is a Carhart's notch. Yes. Okay. What is the most likely diagnosis? So now you know the answer. What is the answer? Come on, guys. Everyone knows the answer. Answer is autosclerosis. Stapedial autosclerosis. Yes. Swatantra, the Paracusis willisii is also given. So answer is autosclerosis. Now I just saw somebody marked B answer instead of C. That also happens. Okay. Sometimes you intend to mark C option, but in a hurry, in tension, you end up marking answer as B or A or D, right? Now this common mistake is seen at least 2 to 3% questions. Okay, that means supposedly you have a 200 question NEET PG, at least 3 to 4 question, maybe even 5 question, you will mark a wrong option even if you know everything. You are thinking you have marked B, but in the exam you must have marked C. And this used to happen with me as well. Okay, this used to happen a lot of time. I discovered when I was giving a lot of mock tests, I realized that I was also making this mistake. So how will I, improve upon this mistake? I will improve upon this mistake by, saying the same letter again, by sub-vocalizing it. You cannot talk in the exam hall, but you can sub-vocalize. So you see, I have seen autosclerosis C. So C, I'm going to put my mark over there at C. Okay, I'm going to make sure that it is C, right? So that is important. So, that brings us to the next tip over here. That is to sub-vocalize the answer. Okay, don't let the stress, overtake you. Okay, this is one of the most important exams in your lifetime. It decides you. It decides which branch you will take. It decides which college you will get. It will decide what kind of a specialist you will be, how good a specialist you will be. This is one of the most important exams in your lifetime. In fact, it is more important than the MBBS, PMT or the NEET UG exam that you gave. Right? So I know the amount of tension is very, very high. When you gave the NEET UG exam, you were competing with students who were not that serious, who were not that focused. Okay, now this, I always say, NEET PG exam is a race between the best of the horses. All the best of the minds in the country are running for a seat. This is the most competitive exam and the stress levels are high. But don't let it overtake you. If it's overtaking you, you should have some tips and tricks to calm you down. Okay? How can you calm yourself down? Read the question. You are not able to concentrate, use the finger. With the finger, move the finger one by one, read the letters. That will make your eyes come back to the focus. You will be able to understand it. You will be able to follow for the finger and follow the question therefore. Okay? So don't let the stress overcome you, and then when you have chosen an answer, then put the finger over there and take the mouse and mark it. Okay? So that way, in between, if you have that movement, you'll be able to bypass it. Take some water, drink some water. That's allowed in the exam. Let it pass in. Right? Okay? बेटा कितना भी कर लें, stress तो होगा, but there is way to beat the stress. Right? Some stress is good. Right? No stress, you will not study. So some stress is good. Right? But take almost that much stress that you can handle. If you are not able to handle, okay, then drink some water, take a minute breather, breathe, take a deep breath in, leave it, okay, release the breath, again do it, 1 or 2 or 3 times, the stress will vanish, your focus will become, come back again, right? Okay, all right, yes, let's come to the next question. A 23-year-old male. Okay, so I'm reading all the chat also, Akshat. Okay, so you're not able to revise the subject, so I'll keep on answering your doubts also in the chat, so you can keep on writing. Okay, so you're unable to revise the subject. I have done once. Unable to focus at all. So yes, that's a common problem with all of you students, that once you have done the subject, you are unable to revise it. So you see what happens, you are reading the 19th subject. It's not 2 or 3 subjects like the NEET UG, it's 19 subjects. In the 19 subjects, by the time you are at the 15th or 16th subject, you have forgotten the first subject. That's a problem. Now how do you overcome that problem? Now to overcome that problem, you see, after 2 or 3 subjects, you have to once go back to your previous subject also and give it some time. Now it is not that possible because the time is limited. So the best way is you keep on evaluating yourself by giving the mock test every month. Okay, so this is for the tip we're preparing for the next exam, next in the December. Okay, right? Or we're preparing for INICT exam, or we're preparing for the FMG exam. So you keep on giving the mock test right from the beginning of your preparation. Every month, give the mock test. As you reach near the exam, you increase the frequency of those mock tests. So when you are giving the mock test, even when you are preparing, you will be focused on the subjects that we have done. So that will help you revise. अच्छा मैंने ये सब पढ़ा था. Now मेरा revision हो गया mock test की वजह से. Right? Okay. Seems like most of the prep faculty are in Allen now. I can't help it. That is how the world is now. Okay. When will the app launch? Soon. The app is launching on 5th of March. Okay. And on 2nd of April, all our videos and MCQ, QMANG, everything will be available to you. Right? Okay. VKP Pal Sir OT. Explain करना पड़ेगा आपको. What do you want to say? Right? All right. So, yes, Ferin, your answer is right. It is CSOM. But let's first look at the question. 23-year-old male patient presented with impairment of hearing in the right ear of about 4 years duration. So 4 years, long history. Again, it's a chronic disease. He gave a history of long standing, again the mentioned long standing, on and off yellowish discharge from the right ear. He had no vertigo or tinnitus. Examination of the ear revealed following findings. So again, spot diagnosis. Okay, again, spot diagnosis. What do you see over here? This is a, this is a large central perforation. Okay, this is a large central perforation. What else can you see over here? Can you see something? You can see over here that the margins are all there. Okay, that is why I said it's a central perforation, right? It is not a marginal perforation. Yes, yellowish discharge, so sometimes it can have mucopurulent discharge, right? Okay, healed margins are there. So question, what is the most likely diagnosis? Come on, guys. Come on, guys. What is the most likely diagnosis? Central perforation. Come on. Yes. Dr. Hashimoto, you can improve your answer. Now we have 2 CSOM over here. Yes. Okay. So answer is CSOM tubotympanic disease. Right? CSM tubotympanic disease. Clear? Okay, I think it's a spot diagnosis once again. Let's go to the next question. Right? So, 10 years old child presented with ear infection with foul smelling discharge for past several years. On otoscopy, following findings are seen in tympanic membrane. What do you see in the tympanic membrane? Yes? Come on, Farin. Now you have over here foul smelling discharge and you have a tympanic membrane finding over here. We can clearly see that finding. What do you see? Okay. Dr. Hashimoto, are you seeing a bulging tympanic membrane? No, pars tensa looks almost normal to me. There is not much bulge over there that you can see. Right? Eruptions, where are the eruptions, beta? There are no eruptions, Akshat. Okay, yes, Farin, you are right. You can see the pars flaccida scutum erosion. You can see that over here, the scutum is eroded. There is a retraction pocket. Pars tensa is normal. Okay, the problem is in pars flaccida. There is a retraction pocket. And you can see some black colored debris over here. Okay, this black colored debris over here. Now that is the dead epithelial cells with some infection, some dead particles. So this is a case of, come on. What is the diagnosis? CSM, what kind? Eticoentral disease. Right? Okay, so now answer the question. What would be the most appropriate next step in management? Yes, Dr. Pukar Adhikari, what will be the answer? Come on. बताओ भाई. Dr. Hashimoto says C, tympanoplasty. ठीक है या नहीं है? और कुछ? Farin says D. अक्षत says B. तो अब क्वेश्चन आता है आपको, टॉपिक भी आता है, आंसर में कंफ्यूज हो गए, है ना? अर्चना says D, स्वतंत्रता says D, Mithu. Now everyone is saying D. Come on. Okay. So see, CSM, eticoentral disease, what is the treatment of choice? Treatment of choice is tympanomastoid exploration. Right? Now, question में क्या पूछा? What is the most appropriate next step? Treatment of choice नहीं पूछा, most appropriate next step. So I know this is the treatment of choice. But is this my answer as well? Should I do something else? Okay, right? So ये देखना बहुत ज़रूरी है, because examiner कभी कभार twisted question देता है राइट. सो मैंने इतना ट्विस्टेड नहीं दिया. आई डिडंट वांट टू डिसअपॉइंट यू जस्ट बिफोर द एग्जाम. Okay, right? But let's look at this. Antibiotic ear drops for 4 weeks. What will antibiotic do over here? Nothing. There is no discharge. We can see a dry retraction pocket with some debris inside. No active discharge coming out. No role of antibiotic over here. Anyways, antibiotic does not help much in etiquantral disease. We have to operate. Okay, so this is not an option. IV antibiotics? Of course, no. There is no use of antibiotics. Tympanoplasty you will never do without mastoid exploration. Okay, tympanoplasty is the answer for, that's the answer for CSOM tubotympanic disease, not for etiquantral disease. Okay, so this is the treatment of choice. This is also the next logical step as per this question, as per these choices. Okay, somebody asks you next appropriate step. So once again, instead of giving this, supposedly instead of giving all these choices, I give the choices over here, you know, workup for PAC, pre-anesthetic checkup. That was a better answer. Okay, what else should be done in this patient? HRCT temporal bone. Okay, so you know I gave you answer as tympanomastoid exploration. Tympanomastoid exploration. Now I am telling you, if somebody gives you this option, tympanomastoid exploration, and somebody asks you, can there be a better answer than that? Yes, there can be a better answer, that is workup for PAC. Now even before workup for PAC, what will you do? You will do HRCT temporal bone. So that is a better answer even before PAC. Can there be even better answer than HRCT temporal bone? Yes, that is your pure tone audiometry. Right? Okay, so Satyam, you really got confused in this question. So the question, first of all, look at the image. This image talks, this question talks about this image. What do you see in the image? In the image, you see that the pars tensa is normal. Right? Right, Satyam? You see pars tensa is normal. Problem is over here in pars flaccida. Okay? So problem in pars flaccida, that means, what do you see? The scutum is eroded. You can see the retraction pocket is there. So that means it is a case of CSM etiquantral disease. Got this much? Okay, so CSM etiquantral disease is there. Now what treatment do you do for CSM etiquantral disease? We do tympanomastoid exploration. Now that I am saying is the treatment of choice. Right? And that is also the answer in this question. Right? That is also the answer in this question. Right? Clear? Yes? Okay. Now, I am saying that instead of this, I can give you some more better choices to make this question even interesting. Okay, you have read this answer, you have learned this answer, and you go to the exam and okay, हिंदी, तो आप एग्जाम में जाते हो और आपको लगता है कि अच्छा, if anyone has a problem in Hindi, please tell me in the comment, then we'll go and do in English, otherwise we are using English language over here. ठीक है बेटा, किसी को प्रॉब्लम है तो बता देगा. Right? Okay, so instead of these choices, supposedly I give you different set of choices. I am cutting the different 3 choices. ठीक है, I am just modifying the question. Right? Now instead of tympanomastoid exploration, I can over here write pre-anesthetic checkup. Right? I can write HRCT temporal bone. And I can write pure tone audiometry. Right? So I have changed the choices. Fair enough? Okay, I'll speak in English and Hindi both. तो क्या किया मैंने बेटा, मैंने चारों choices में से 3 choices दोबारा से change कर दी. Question वही है, language वही है, photograph, everything is same. Right? I have just changed the choices. Okay, now what will be my answer? Question is not talking about the treatment of choice. Question is talking about the most appropriate next step. Okay, most appropriate next step. Right. So when the question is talking about the most appropriate next step instead of anything else, now what will be my answer? My answer over here, most appropriate is first you will do a pure tone audiometry. You will see the amount of hearing loss. That is most important before going for ear surgery. That is the next step. Okay. Then you can also do a HRCT temporal bone. Okay, we don't do HRCT temporal bone in all the patients, especially in third world countries, in developing countries. We do in developed countries, but not in developing countries. We can also do X-ray. Okay, so not in all the countries do we do HRCT temporal bone. Okay, we do it in developed countries, but in countries like India, if the patient is poor, we can also go with X-ray, right? And then we can do pre-anesthetic checkup. Of course, that has to be done because the patient has to be taken for surgery, right? Okay, so Ramakrishna, yes, I have left Prep Ladder. My contract with them has been terminated prematurely. Okay, so that's very unfortunate, or that's very fortunate, because now I am at a better place. Okay, and I'm really happy and we are able to give what all the students need. All right, so now if I modify the question, the answer now becomes pure tone audiometry. I have just changed the options. Okay, so now as we were talking about, what do we gain from this question? What is the tip? Now the tip over here is, once again, what I told you earlier is that you know the question, you know the answer, wonderful, but there can always be better option. Okay, and this tip is not valid in your personal life. हाँ, आपने डिसाइड कर लिया अब इस लड़की से शादी करनी है, तो शादी से 2 दिन पहले ये नहीं सोचना है कि देयर कैन ऑलवेज बी ए बेटर ऑप्शन. ठीक है, वो डिसाइड हो गया तो हो गया, राइट? दिस टिप इज ओनली फॉर द MCQ, right? That there can always be a better option and you have to always look for it. Okay, this tip is only and only for the MCQs, not for the personal life. Okay, let's go to the next question, right? Okay, so 5 years old boy. Boys are very happy. So 5 years old boy presents with torticollis as shown below, along with a tender swelling behind the angle of mandible and fever. He had history of ear discharge for the past 6 years. Examination of the ear showed purulent discharge and granulations in the ear canal. So this much. Okay, so you see, most questions I have divided into 2 slides. Because I don't want you to jump to the options. I first want you to understand, look at the image, understand the clinical history, and then go to the actual what is asked out of you. Right? Okay, so that's the major trap in OBG, ENT and surgery question. Yes. Okay, so let's look at this question. So we know that's how we all do, because that's how our life is. Sometimes we think we are going to operate a simple case, it comes out to be a very complicated case, right? We think it's a 5-minute job, it becomes a 5 hours job. So that sometimes a lot of time becomes, so we are trained like this, and that's how we ask the questions also like this. Okay, so 5-year-old boy presents with torticollis. So you can see over here, torticollis, severe torticollis, along with a tender swelling behind the angle of mandible and fever, right? So why do we have torticollis? Torticollis is because of generally spasm of one muscle, that is SCM, sternocleidomastoid muscle, right? He had a history of ear discharge for past, okay, it cannot be 6 years, sorry, it has to be like 2 or 3 years, right? He had a history of ear discharge for the past few years, let's say 3 years, right? A 5 years boy cannot have a discharge for 6 years, right? So it has to be 2 or 3 years, right? Okay. All right. So, yeah, I'm maximum zoomed out. That's a setting. We cannot change Muthu at right now at this moment. Okay. So, history of ear discharge for the past 3 years. Now, so 3 years history, we can suspect CSOM. Right. So, CSOM having spasm of the SCM. Why will the CSOM involve SCM? That's a question. Examination of the ear showed purulent discharge. Now, which kind of CSM will have purulent discharge? The answer is eticoenteral disease. Okay, right? Yeah, I can see little bit question is being cut, but don't worry, I'm speaking it along with this thing so that you get it, and then I will also share the PDF in the group, in the Telegram group of Alan Next. You will get the PDF as well. I'll share the link of the group in the comment section, so don't worry. Right. So, 5 years old boy presents with torticollis as shown below, along with a tender swelling behind the angle of mandible and fever. He had history of ear discharge for the past 3 years. Examination of the ear showed purulent discharge and granulations in the ear canal. Right. So, with the history we have deduced that this is a case of CSOM, okay, eticoenteral disease. Right, along with, now this has come to SCM. This has come to SCM. Now, when does this comes to SCM? This comes to SCM when we have something which is known as, come on, Bisoled abscess. Right. So, something that is known as Bisoled abscess. Yes, very good. Swatantrata, very good. Right. So, most probable diagnosis is, answer is Bisoled abscess. Yes. Right, Muthu? Right, Swatantrata? Answer is very correct. It is Bisoled abscess. Right. Okay. So, complex questions, they can be simplified if you think logically. Always try to simplify the complex question by thinking logically. For logical thinking, you need patience. Okay? You need knowledge. Knowledge comes from revision, multiple revisions. Okay, multiple revisions gives you lot of knowledge. They also give you lot of confidence. Okay, and above all, what you also need is practice. Practice of these kind of questions. Right. So, I am now today telling you what are the tips and tricks how to solve these questions. Right. So, this is all you have to do. Right. Okay. Let's go to the next question. 30-year-old female presented with vertigo lasting for a few seconds. Okay. Associated with, I think it's better now, associated with movement of head posture. Name the maneuver done as shown in the image to treat the patient. Right? Yes. So, you can all see this maneuver. You can all see this maneuver. Right? So, what is it? Come on, guys. Come on. This is your Apley's maneuver. Okay. Yes. Very right. Okay. So, Apley's for treatment, diagnosis done by Dick Solpike. Wow, very good. Okay, answer of course, diagnosis of course is BPPV. Right. So, very clearly mentioned vertigo lasting for few seconds, associated movement of head posture. Right. Okay. So, that clearly makes positional vertigo, answer is BPPV. treatment of choice is Aplase. What we can see over here is Aplase is being done in this diagram. In this photograph, we can clearly see the Aplase is being done. So now how do we do Aplase? You make a patient sit on an examination table, then you turn, supposedly you have to do for the right side, you turn the patient head by 45 degrees to the right side, and then you make the patient go supine. Okay, so you make the patient go supine, head hanging little bit, okay, approximately 30 degrees, the head hangs at the edge of the bed, and then you make the patient, so right now the patient is looking at the right upper corner of the room, now you turn the patient and the patient now looks at the left upper corner of the room. Okay, so you turn the head by 90 degrees. And then you rotate the entire patient by another 90 degrees. Okay, now the patient which was looking at the left upper corner will be looking at the left lower corner of the room. Okay, right, so patient is looking at the left lower corner, and then you bring the patient back to the sitting position. That is your Aplase maneuver. Right, okay, so this is Aplase maneuver as clearly shown in this series of photographs. Right, clear? Okay, so that was this question. Let's come to, so I have kept some question from all the topics. I think already 1 hour has passed and we have been able to discuss various topics of ear. I'm really happy. Ear is a major topic of ENT, as we know, and a lot of interesting questions are asked from ear, right? So I've been able to touch base with most topics. Let's go over here to the nose, right? So yes, nose spot diagnosis, clear cut. 70-year-old patient presents developed following lesion over nose for last 2 years. 70-year, 2 years. Okay, carcinoma, keratoacanthoma, melanoma. What is this? What do you see? What is the most likely lesion? Spot diagnosis. What do you see over here? Come on. Heaped up margins, rolled margins, heaped up margins. Answer is basal cell carcinoma, BCC. Very good. Everyone is giving the right answer over here. It's a repeat question that was asked earlier. Okay, so just kept it from the external nose. One thing, spot diagnosis, BCC. Right? So again, let's come to the next question. 2-month-old child is brought to the hospital with a compressible swelling at the root of the nose. See the clinical picture. Right? What is your diagnosis? Come on. Come on. Spot diagnosis. This is also a spot diagnosis. 2 months old child. Spot diagnosis. Yes. Okay. So this is a case of compressible swelling. This is most likely 2 months. No, beta, this is not a dermoid cyst, Archana. Okay. Look at the choices. Most likely diagnosis: AV malformation, lacrimal sac cyst, ethmoid sinus cyst, meningoencephalocele. Look at the choices. Mithu, look at the choices. Okay, it's a compressible swelling in a 2 months old child and at the root of the nose. Whenever you get such a history, okay, you have one diagnosis in your mind. Okay, see, this is not on the side. It cannot be lacrimal sac cyst. Okay, it cannot be ethmoid sinus cyst coming out over here. Compressible swelling. This is a case of meningoencephalocele. Right? Remember, okay, so yes, Vikas, it's a case of meningoencephalocele. This is a very, very common spot diagnosis over here. Compressible swelling at the root of the nose. 2 months old child. That is the biggest hint over here. 2 months old child. Yes, okay. So interesting question over here. You can do a transillumination test over here also. And remember, there is a saying over here, when you see a polyp in a child less than 2 years of age, polyp in a child less than 2 years of age, right? think about meningoencephalocele. Meningoencephalocele, right? Yes, so it is most common is in the occipital areas, but they are also common in this area, in the frontal areas over here also, and these are commonly seen over here, okay? So yes, transformation test, if it is mentioned, because that clearly improves your chances of getting the right answer, but if you look at the other choices like lacrimal sac cyst, ethmoid sinus cyst, they are not at all possible. AV malformation will not have such a smooth cystic appearance. Right? Okay. So answer is meningoencephalocele. Next question. This is a patient of DNS. Not much DNS we can see. On the other side, there is a slight DNS over here. Okay, you can see this slight DNS over here. All right. Identify the arrow mark structure. So they are not concerned about DNS. This side, we have a good cavity. Identify the mark structure. Come on. Beta cystic hygroma is not mentioned in the choices. Right, Kishore? Okay. So what was, and cystic hygroma will not appear at this place. There are other places to appear. So the answer according to choices was meningoencephalocele. Right? Let's come to this question. Come on. What is the answer? Yes, Bhavna, is it middle turbinate? Are you sure? Satyam, uncinate process. D. Archana, B. Middle turbinate. Okay. Yes, Apurva, Hashimoto, Ramakrishna, A. Inferior turbinate. So I think I have got all the choices other than septum, because I have marked the septum already. So this we can see, this is the septum. We talked about the DNS. Right? Now look over here. How do you identify this question? How do you mark this question? First of all, look at this image. What is this? What is this? That's the floor. That's the floor. Okay. So what you can see over here is the floor. What is near to floor? Near to floor, you have the inferior turbinate. Another thing, inferior turbinate, anterior wall, anterior end is attached to the lateral wall like this. This is inferior turbinate. Right? Guys, this is your middle turbinate. This is your middle turbinate. Okay, this photograph actually is taken with the help of an endoscope, but this is not an endoscopic picture. We have not put the endoscope inside. It is right at the, starting of the nasal cavity, right at the nasal vestibule. We have taken this photograph by keeping our endoscope over here. This is the picture. This is the finding you will get when you will do anterior rhinoscopy of any patient. This is what you will see. This is what you as undergraduate students are supposed to know and understand. Okay, right? So Ramakrishna, I'm sure you will not make this mistake again. But this is an anterior rhinoscopy image. This is what you should always know. If you have ever visited ENT OPD, seen some ENT patients, done anterior rhinoscopy, you should never make this mistake. Remember, on anterior rhinoscopy, superior turbinate is not visible. That can be seen only when you put the endoscope deep inside. Okay, you can only see inferior turbinate and middle turbinate. Right? Okay. So, what next? What is the next tip over here? The next tip over here is, these are what are being asked are clinical questions. Okay, so what is being asked of you? Clinical questions. So clinical questions means your clinics, your clinical postings. They are important. They were important. They made you the doctor that you are. Okay. Now, Satyam, in this image, you cannot see the unsnit process. This is an anterior rhinoscopy image. Okay. We have taken it with the help of endoscope, but it's like an anterior rhinoscopy image. So, you cannot see the unsnit process. It is hidden deep. Right. Okay. It will be somewhere over here, where we have the middle turbinate. Okay. But you won't be able to see the unsnit process in this. So I was telling you, clinical postings is very important. the questions nowadays are being asked which you saw in clinical postings. Sometimes they may not be given in your textbooks also. Right? So clinical questions are being asked nowadays. So the tip is, when you go for your NEET PG exam, you don't know that you have read it, think, have you seen such a patient in your clinical posting? Okay, think about it. If you have seen such a patient in your clinical posting, then also you can mark the answer, because examiner is giving questions from clinical postings. Right? Okay, next question. Identify the air cell marked with red arrow in the CT scan of nose and paranasal sinuses. Bulla ethmoidalis, agar nasal, Heller cell, Onodi cell. Come on. We have discussed this CT scan. CT scan of nose and paranasal sinuses are very important. They are being asked in the exam these days. Okay, yes, very good. So Ramakrishna, Sutantrata, Sinusan, Mitu, very good. Is this? Yes. So this is your, come on, infraorbital cell or Heller cell. We can identify over here that this is the most consistent cell of ethmoid known as bulla ethmoidalis. And below that, below the bulla or below the orbit, we have infraorbital cell also known as Heller cell. Onodi cell is the posterior most cell. Okay, next to optic nerve, ON. Right, agar nasal cell is the anterior most cell. It is next to lacrimal sac. Right, next to lacrimal sac. Right, okay. Let's go to next question over here. 70-year-old male presented with left-sided nasal obstruction and blood-tinged nasal discharge. His endoscopy and CT scan findings are shown below. What do you see over here? Let's read the complete question. Most probable diagnosis. Right? So, come on. Yes. Yes. Okay. 70-year-old. So, Apurva is asking, is it inverted papilloma? Question mark. Sutantrata is confident. What is the age group of inverted papilloma? Age group of inverted papilloma is 50 to 60 years. Can it happen in 70 years? Yes, it can happen in 70 years. What else can happen in 70 years? Malignancy. Look at the choices. Look at the choices. Inverted papilloma is one of the options. Yes. Yes, it is one of the options. Nasopharyngeal carcinoma, there is no option. Archana, Kishore, there is no option. Nasopharyngeal carcinoma is not the option over here. Right? Okay, we have nasopharyngeal angiofibroma. Can it be nasopharyngeal angiofibroma? No. Why? 70 years. Angiofibroma is seen in male adolescent age group. ENT का कोई क्वेश्चन नहीं आता जिसमें एंजियोफाइब्रोमा नहीं हो. कोई ऐसा पेपर नहीं हो सकता जिसमें जेएनए के बारे में बात नहीं हो. जेएनए पे 90% टाइम्स क्वेश्चन एग्जाम में आएगा. अगर क्वेश्चन नहीं आया तो किसी ना किसी ऑप्शन में जेएनए आएगा. राइट? सो जेएनए इज ऑलवेज देयर. बट इन दिस क्वेश्चन जेएनए कैन नॉट बी देयर. इट इज सीन इन एडोलेसेंट टीन एज ग्रुप. ओके, राइट, मेल पेशेंट्स. सो जेएनए यहाँ पे आउट हो गया. राइट? ओके. Can it be inverted papilloma? Yes, it can be inverted papilloma, right? But let's look at the other options. Can it be esthesioneuroblastoma? So esthesioneuroblastoma starts from the cribriform plate where we have olfactory neuroepithelium. Esthesioneuroblastoma, also known as olfactory neuroblastoma. Can it be a esthesioneuroblastoma? No. You can see over here that this is empty. This malignancy, look at the CT scan, is involving this malignancy, this tumor, whatever it is. Okay, I should not call it as a malignancy. So whatever it is involving one side nose and maxilla. Is it involving the cribriform plate? No. So it is not a case of esthesioneuroblastoma. So we are left with two options. Inverted papilloma or squamous cell carcinoma of the maxilla. What is it? What is it? Now let's look at it. Let's look at it once again. What do you see over here? Yes, guys? Do you see any erosion? No. Do you see any invasion? No. It is completely filling the maxilla. Has this mass eroded and gone into the orbit? No. Has it eroded and gone into the oral cavity? No. It is pushing the lateral wall of nose or the medial wall of maxilla and entirely being involved. So it is not likely to be a malignancy. It is most likely a benign lesion. Right? What do you look in this photograph? In this photograph, when you see, you can see that some parts it is going in. Some parts are going in. Right? It is polypoidal, but some parts are going in, just like a case of inverted papilloma. So you see, there is no invasion, there is no erosion. All of this goes, it's a homogeneous mass. It goes in favors of inverted papilloma. So most probable diagnosis. The word used is more probable diagnosis. Satyam, it is not SCC because we are not seeing any invasion, any erosion of the bone over here. So I said most probable diagnosis. How will you confirm it? How will you confirm it? You will confirm it with the help of a biopsy. Right? You will confirm it with the help of a biopsy. Right? Okay. So, next tip over here. Sometimes you get these questions. The next tip. Sometimes you get the questions where there is confusion between the last two choices. Okay. So there is confusion between last two choices, and this happens in so many questions. Out of 4, you are able to rule out 2 choices, but 2 choices are still left. So there is confusion between these last 2 choices. Now what to do? Okay. First of all, one of them is answer. Okay. So if you are not able to understand which one to mark, don't leave the question. Why? The probability of marking and getting the right answer is 50%. It's a very, very high probability. So always mark the answer, even if there is a confusion. Okay, even if you are not sure, always mark the answer if you are confused between 2 choices. Never leave such a question. Right? Okay, supposedly you have done 3 rounds. Okay, remember we talked about the rounds earlier. So we have done the 3 rounds and there are still questions left about which you don't know anything. So remember, in NEET PG, you have plus 4 marks for every question. You have minus 1 for every wrong answer. Okay, so every right plus 4, every wrong minus 1. So that means supposedly I have 4 questions left with me and I don't know anything about it. Okay, if I mark all of them as B, or I can mark all of them as C, right? These are the 2 best choices that are supposedly set. I always go with B, but you can go with C as well. So if you mark all of them as B or C, now the probability says 25% should be correct. So out of 4, 1 should be correct. You will get 4 and minus 3 is equal to 1. You still gain 1 extra mark, and that 1 extra mark can increase your rank many times. So remember, never leave any question in the NEET PG as well. Okay, not even a single question should be left in the NEET PG. Yes, in INICT, when the negative marking is plus 3 and minus 1, then over there you can leave them because there is no extra benefit. But in NEET PG, plus 4 minus 1, always mark all the options. Okay, always mark all the answers. Don't leave any question unanswered. Right? Okay. Guys, are the tips useful? Or should we just discuss the question? Come on, comment in the box. You want to keep getting more tips? Please, come on. Tips चाहिए? Questions. Look at the questions also. Yes, Satyam, Hashimoto. I think my chat has stopped. I can't see any more answers over here. Come on. Okay. Right. Hanji, Kishore, Hashimoto. Come on. All right. चलो तो आगे बढ़ते हैं. What can you see over here? Swatantrata, very focused, double dense. 35-year-old male presents with nasal polyp. Okay, so nasal polyp and mucinous nasal discharge. Right, mucinous nasal discharge. His CT scan is given here. So what can you see in the CT scan? What can you see in the CT scan? You can see in the CT scan that there are densities over here. Okay, it's a heterogeneous appearance. We call it as double dense appearance. So 35-year male, nasal polyp, mucinous nasal discharge. Okay, this goes clearly in favor of allergic fungal rhinosinusitis. What else can you see in the CT scan? Unilateral disease. There is no invasion. There is no invasion over here. You can see the orbit. There is no invasion. There is some erosion. You can see there is some erosion. Right? So erosion can be present in AFRS, but this erosion is generally because of pressure. There is no invasion. Right? Clear? So answer is double density over here. Yes, the criteria that we use is Bent and Kuhn diagnostic criteria. Very happy with your preparation for ENT, Swatantrata. Very happy. I wish you best of luck for your exam. Right? If you keep on doing like this in all the subjects, you will definitely score a very good rank. Right? Okay. Let's go to the next question. Oh, I think it's all blued out. I don't know why. Right? Which surgery is shown below? It was supposed to be red. I don't know. Which surgery is shown below? Enteral washout, functional endoscopic sinus surgery, Cardwell Lux operation, Lynch Howarth operation. Come on, guys. Yes, the answer to this is Cardwell Lux operation. So you can see over here, a opening is being made in the maxilla. Okay, opening is being made in the maxilla, right, from the oral cavity. So whenever we are entering into the maxillary antrum from the oral cavity, this is known as Cardwell Lux operation. All right, let's quickly go to few more questions over here. Following instruments are useful in which surgery? Yes, following instruments are useful in which surgery? Come on. What do you see over here? What is being planned when you are using all these instruments? Yes, what you can see over here? I can see a Tilly's nasal packing forceps. Okay, that I can see. What else I can see? I can see the nasal pack. I can see over here, that is the lignocaine. Okay, so anesthetic is there. But what else is there? You can see the nasal splint. This is your external nasal splint. What else can you see over here? You can see the Ashes forceps and you can see the Welcham's forceps. Okay, you can see the Ashes forceps and you can see the Welcham's forceps. Okay, so that means these are the instrument set which are being used for nasal bone fracture reduction. Right? Okay, so these instruments are used for, okay, if only this was there. If only this was there, that means we are going to do a nasal packing for epistaxis, right? You don't see any FES instruments, you don't see any endoscopic forceps and all, right? So, of course, these are not FES instruments, right? These are not FES instruments, and intranasal polypectomy anyways is not done these days, but these are not polypectomy. You don't see any polypectomy forceps and all these things, right? So the answer to this is close reduction of the nasal bone fracture. Right? Okay. Let's come to this question. Come on, guys. Favorite question of the examiner. Favorite question. Asked multiple times in the exams. Every question. As I was telling you earlier, Sutantrata has started answering it. Very good. Okay, Dr. Shifana, welcome. Right? Dr. Hashimoto, Dr. Srinivasan. Okay. Yes, so very good. I am very happy. Now you are able to diagnose this. 18-year-old male. Presented with chief complaints of recurrent epistaxis with nasal blockage. Okay. So recurrent epistaxis, nasal blockage. On examination, polypoidal mass is seen going from nose to nasopharynx, completely occupying the posterior vena as seen in the image below. So you can see the image, you can see this on CT scan, enhanced uptake of contrast is seen. So entire history of JNA is described in one question. Recurrent epistaxis, nasal obstruction, polypoidal mass, okay, right, nose to nasopharynx, CT scan shows enhanced uptake. Most likely diagnosis, straightforward question, nasopharyngeal angiofibroma. Right? Okay. Reshma, I am in 11th and aim preparing for NEET UG 2024. Any tips? Guys, welcome. Very enthusiastic students over here also. Okay, yes, we'll give you a lot of tips. Okay, the tips are universal whenever you are solving MCQ question. The tips are universal whether you are doing a NEET UG or a NEET PG. The basic tips of not losing your calm, maintaining your patience. Okay, they are common to everyone. All right. Okay, let's go to the next question. Now, a 7-year-old boy was seen by an ophthalmologist for headache that has been present for the last few months. Headache. Manohar has given a very useful tip. Join Alan Kota. Yes. Okay. So, 7-year-old boy was seen by an ophthalmologist for headache that has been present for last few months. Headache was maximum between the eyes. However, there was no ocular cause for such a headache. The child was referred to an ENT specialist. You see, this question इतना ज़रूरी नहीं था यार, डायरेक्टली ENT वाले के पास आ जाता है ना. The child was referred to a ENT specialist. Right? Who noticed nasal intonation? See, sometimes question is given to waste your time. That is why I am saying when you see an image-based question, look at the image first. Anyway, so now we'll look at the image later. We have started with the history. Right? No, beta, there is no thumb sign. Dr. Shifana over here, there is no thumb sign over here. Okay? Right? Who noticed nasal intonation of voice and bilateral nasal obstruction? The mother reported her child snores during sleep and has repeated attacks of chest infection. So there is history of OSA, obstructive sleep apnea. And now the infection, it is affecting the chest as well. Okay. What do you see in the X-ray? What do you see in the X-ray? Come on over here. This is X-ray of a child. You can see unerupted dentin. What else can you see over here? You can see over here that there is a mass arising from posterior superior wall of the nasopharynx, and you can see a very, very small airway gap left over here. Right? Very small airway gap left over here. Right? So this is a classical case of adenoid hypertrophy. Yes, most of you have got it correct. This is a classical case of adenoid hypertrophy. Right? Nasal obstruction, nasal intonation of voice. Okay, what kind of voice? We have rhinolilia clausa. This is known as rhinolilia clausa. Right? Okay, adenoid hypertrophy. All right. Okay, right? So once again over here, yes, Shifana, rhinolilia clausa. Now once again over here, don't jump straight away. Look at the history, look at the X-ray, look at this image, and then you are able to make the correct diagnosis, right? Okay, simple questions sometimes can go wrong as well. So be careful with the simple question as I was telling you. 30-year-old female, next question, come on. 30-year-old female underwent tooth extraction for dental caries. Now she presents with fever and trismus. Oropharyngeal examination is revealing that tonsils are pushed medially. There is also a swelling in the neck at the upper border of SCM muscle. Now, why I have kept this question? Because this is one of the most controversial question, okay, in ENT. Because every teacher gives you different answer, right? And it is also the most repeated question in the history of ENT questions. Most repeated. This has been asked 5 times continuously in the FMG exam. For 5 sessions they kept on asking it continuously, one after the other, right? Of course, I have elaborated the question a little bit more than what they have done, but yes. So Bandy says Ludwig's angina, others are saying parapharyngeal. Okay, Sutantrata is also saying parapharyngeal, Ramakrishna is saying Ludwig's. सत्यम अपर्टा कहाँ मिलता है बेटा? अपर्टा मिलता है क्लेफ्ट पैलेट में. राइनो ले लिया. अपर्टा की बात कर रहे हो प्रीवियस क्वेश्चन का, उसका आंसर है क्लेफ्ट पैलेट, राइट? ओके, सो स्वतंत्रता, यस, आई हैव एक्सप्लेन्ड इट क्वाइट इन डिटेल इन माय लेक्चर्स आल्सो. लुडविग्स किशोर. अच्छा, क्वेश्चन जरा दोबारा देखते हैं, इसमें पूरा क्वेश्चन देख लो. मोस्ट लाइकली डायग्नोसिस इज रेट्रोफ्रेंजियल एब्सेस. लुडविग्स भाई चॉइस में है, कंफ्यूजन तो है, राइट? पेरिटॉन्सिलर एब्सेस, पैराफ्रेंजियल एब्सेस, right? Okay, yes, right. So 30-year-old female underwent tooth extraction for dental caries, right? So पहली बात, many of you, आपको confusion होता है between parapharyngeal abscess and peritonsillar abscess, और ये confusion बहुत बच्चों को है, right? So let me solve this confusion for once and for all, for everyone, right? So सबसे पहले जो peritonsillar abscess है, right? Hi MD Gujar, okay, hi doc, right? So peritonsillar abscess. Now number 1, peritonsillar abscess means tonsils are involved. Tonsils कब involved होते हैं? क्या हिस्ट्री होगी पेशेंट की? सोर थ्रोट, फीवर. Okay, parapharyngeal abscess, sore throat, fever can be there. What else can be there? Dental caries. History of dental caries, tooth extraction. Those kind of histories are there, right? Then presentation is same. Pain in the throat, dysphagia, odynophagia, fever, all of that is common. So we cannot differentiate on the basis of that. We are not talking about that. Okay, right? So what will be the differentiating feature over here? The examiner will tell you the tonsils, they are red, they are congested, okay, they are hypertrophied, they are increased in size, okay. So much increase in size, they have reached midline. They have reached midline, okay, right? Now, over here, what will the examiner say? The examiner will say tonsils are pushed to midline. Tonsils are pushed to midline by swelling in lateral wall of pharynx. See, major difference. You see, tonsils are not coming to midline on their own. Tonsils are being pushed. What else can the examiner add in the history to even elaborate and make it further? See, parapharyngeal abscess will come out. Okay, so parapharyngeal abscess comes in the neck, and you can see there is a swelling in the upper border of SCM. So I have shown this swelling also to you. so that this question is pretty clear. There is no controversy in this question, but similarly, such questions are being asked and there should not be controversy in the exam. So you see, tonsils are pushed medially and there is a swelling in the lateral aspect. Okay, what else? Anything else? So swelling is mentioned, in the outer swelling is mentioned, that means it is a case of parapharyngeal abscess. Right? What else? Trismus. Trismus. Now, trismus is because of involvement of medial pterygoid muscle. So, if there is trismus, it means parapharyngeal abscess. Can peritonsillar abscess have trismus? Yes. Yes. This thing can also have trismus. Yes, peritonsillar abscess. But to have trismus, peritonsillar abscess has first go to parapharyngeal space, involve the parapharyngeal space, become a parapharyngeal abscess as well, and then it can go and cause trismus by again involving the medial pterygoid muscle. Right? So remember this thing. So peritonsillar abscess can have trismus again by the same muscle, medial pterygoid. Okay, again same muscle, which muscle? Medial pterygoid. Okay, but it involves the parapharyngeal abscess. So trismus actually means parapharyngeal abscess. Hot potato voice can be there in both of them. Okay, also known as muffled voice, it can be there in both of them. All right. Okay, look at this question. Okay, so this will be the last question for the day. We have many questions, and I'll try to do some more session before the exam also. Right, I'll try to do. So there are more questions that I have. ENT is a never-ending topic, but for today this will be the last question that we'll have. So let's look at this question, and come on. A patient presents with sore throat, fever and pain in the ear. Examination of the throat shows the following findings. He can be treated by the following except. Yes. Yes. So what do you see over here? What do you see over here? You see over here that this patient is having acute tonsillitis. He is having acute tonsillitis. And what do we have in acute tonsillitis? We have streptococci, hemolytic streptococci. That is the most common causative organism. So what can you treat? How can you treat? You can treat by penicillin. You can give second generation cephalosporins. Okay, you can clearly see over here. You can see penicillin. If penicillin is not advised, it's not advisable. Patient having sensitivity to it. You can also sometimes give macrolides, but you do not give ciprofloxacin. That is generally a gram-negative antibiotic. So it has no role over here in the tonsils. So answer is ciprofloxacin. Okay. So you see, this question is started in ENT. It ends in pharmacology. So nowadays we have an era of integrated questions where question starts in one topic. Okay, right. So this question started in ENT, then it used the knowledge of microbiology, what bacteria, what organism is causing it, and the answer was in pharmacology, right. So you cannot ignore your subjects. Okay, so with the next coming in, with the next exam coming in, it may be a clinical exam. It may only have ENT as one paper. It may have micro as medicine as one paper. But if you have ENT, micro will always be involved. Physiology, anatomy is obviously involved. Pharmacology will always be involved. So you cannot lose touch of your basics. Okay, right? So yes, so these were the questions that I was discussing. So Mubasir, we are already at the end of this. Right. So I just wanted to say a few things before I end this session. Most important thing that you are going for this exam is to believe in yourself. You can do it and you will do it. Okay, it will not be an easy path. All right, you always have challenges. This is one of the biggest challenge that you are going to face. Have faith in yourself, give your best, and I'm sure you will all be able to succeed in your life. All right, so this is Dr. Sarvejeet. You do follow this channel, the Learn Next, you subscribe to it. All right, so that you are able to get daily updates. We are launching, we are having so many videos which are coming every day, and we are launching different programs to help you out. So do subscribe to this channel, okay, so that you can get daily dose of the knowledge over here. Thank you so much. Okay, thank you everyone. All right, I'll try to have more session before the exam, right? And thank you everyone for joining me over here and contributing to this session. Thank you everyone.